Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert here today with my amazing co-host to discuss some very, very cool topics, Dr. Millicent Rovelo. How are you?
I'm doing excellent. How are you?
I'm doing great. I think we got a cool topic today.
We do have a cool topic. We have a couple of cool topics, but we're going to start with this one.
I want to start with...
Oh, boy.
You know, I suggested my favorite rants.
Oh, well, and you know what? You're going to have to get me earlier in the day.
Okay, we won't do that today. So this is about endoscopic brow lift versus subcutaneous brow lift.
Yes, and those are some very big words. So we are going to define them and talk about the actual techniques and then when you would do each one so we can get a general understanding of what it is we're talking about.
So if you were like some trendy podcast host, what you would have said is like, that's a lot, so let's unpack those terms. I can't stand when people say that. I want to like reach through the speaker and just give them a little like,
stop it.
Don't say things like that.
Well,
but you didn't.
I'm glad I didn't.
Yeah, because I could have slapped you actually right across the table from me. I would have just been like, so we need to unpack those terms. So let's unpack them.
No, let's define them.
Yeah, let's define them.
Yeah.
Yeah, it's just like, I don't know why people say things like that. Does it just have to be like all like...
Yeah.
Anyway. Subcutaneous brow lift. Let's start with that. That's under the skin. Subcutaneous, the cutis is the skin, so that is a very Latin term. And sub being below. So this is where you're lifting the brow using an under the skin approach. How is that for unpacking that?
Yeah, that's pretty good. I think that the reason it's important to know that is because this is a very superficial layer. The face and the scalp have several layers kind of going from superficial to deep, from the surface of the skin down to the bone. And you can operate in any of those layers. And this is the subcutaneous layer. So it's the one that's right under the skin in a very, very thin fatty layer. And that's different than the endoscopic brow lift, which is a totally different layer.
Yeah, and that can be actually done in two different layers, just for those of you who really want to get technical. It can be done in a subperiosteal layer, which is how I prefer to do it and how you prefer to do it. That means that you cut down through the skin, down through the soft tissue, and get down onto the frontal bone of the forehead and the skull, and you dissect the tissues off of the bone so that you can move them around. You free them up, you loosen them up, and then you can bring them into position and hold them in various ways, which we'll talk about.
Right. So this is the deepest layer you can do. So the one you just described is about as deep a dissection as you can go. You're literally right on the bones of the face and the scalp. And then the subcutaneous is about as superficial as you can go. And
there are some people that do stuff in between those layers, but for our purposes, since we don't really do that, we're not going to talk about that.
Yeah, that's sort of a little bit of a different spin-off.
Yes. So typically, when I see patients, I'm talking to them mostly about endoscopic subperiosteal brow lifts, where you're moving the whole forehead as a composite, literally small incisions that are made behind the hairline.
Behind the hairline, typically, in the hair.
Yeah, it's in the hair. You're basically making an incision. For me, it's usually about 1.5 inches long over what's known as the temporal crest. There's a little bony prominence you can feel where the temporal muscle, the muscle that you kind of help chew with, transitions to the bone of the top of the head. And that's sort of where I make the incision. And it's, this is available on my TikTok and my Instagram, and you can see how those markings are made and how those cuts are made, et cetera. But what it does is it allows you to get down to the layers where the action is to lift the brow. Right. This is usually combined with a mid-face lift as well, which we don't have to talk about today, but we'll probably get into that, in the near future. And the concept is that you move the whole brow and forehead as a composite. In other words, all the tissues move together.
Right. And you can, through this deep approach, release all of those tissues elevate them, put them in the position that you want, a more higher elevated brow position, and then you can put a series of fixation sutures or some kind of endotyne device, some kind of fixation device to keep those soft tissues in a different or new position. You can trim a little bit of skin if you want to make it a little bit extra tighter, but the whole idea is that this work is done deep and the sutures are behind the hairline where they're more easily hidden.
Yeah. And it works. It's great.
And it works, and it's great. And the reason it's called endoscopic, the reason it has this fancy term, is because a lot of times this was originally done using a camera, like a little camera retractor that you put to go into this deep space. Because you are in a deep space, you're kind of operating in a tunnel, in a hole. So to be able to see, you'd put these cameras and these lights in that deep space, and then you'd watch where you are on an external TV screen. And plenty of people still do it that way. I find I can kind of just do it by feel. Once you know where you are and you're in that right plane, you can do all the releasing bluntly. You don't always necessarily need to have a direct visualization. So it can be done either way, but that's the origin of the term endoscopic.
And we call that the smart hand technique.
Yes, the smart hand. My hands are quite smart.
Yeah, because they're going where
exactly
there's where to go.
Where I am, I can feel what's being released. Yeah.
I typically will use the endoscope if I'm doing the medial brow, the brow over the nose, basically. If that part needs to be elevated,
right.
which is not too frequent, but it's not zero. I wind up doing medial brow lift as part of the whole brow lift, probably like 1 in 25 brows.
Yeah. Most people just need the outer.
They want the lateral.
Corners.
Yeah, because if you just lift the medial, it makes you look like you've lost your keys or you don't know where you parked your car.
Quizzical.
Yeah, it doesn't look good. It's not cute. The other thing that we've abandoned in my practice, I don't know if other people do this, but back in the day when I learned to do endoscopic brow lifts, which for those of you who are keeping score was 1993 at the first endoscopic plastic surgery course at Emory University that I was with it was back when Thelmon Eves, Monty Eves was a resident at Emory. The visiting professors who were doing the teacher were Roland Daniel and I think Nicanor Issei. It was crazy. And then, the participants were guys like John Tebbets and R.I.P. and Sherelle Aston. And it was really amazing. And the concept was, at that time with the brow lift, that you would remove muscles. They would cut out the corrugator muscles. They'd cut out procerus muscles to stop the furrowing of the brow. And what that did was create a lot of very odd muscular movements. So we've kind of gotten away from that.
Yeah, that it leads to this very asymmetrically moving, unnatural kinetics.
Yeah, it wasn't good. Yeah. But I think some people still do that a little bit. I don't. I like to just lift the brow, position it accordingly, and life is good. And then I fix it in position by stitching it, typically with some deep sutures that are all along the sides of the, even the cheek sometimes, and if we're doing a mid-face, obviously down into the mid-face. But those sutures are placed into the soft tissue and then sutured to the deep temporalis fascia, which is the muscle, the thick coating over the temporal muscle, again, the muscle you chew with. And it holds great. Other people like to use the endotyne device. Are you a fan of the endotyne? Or?
I do like the endotyne here and there. I prefer using sutures, but if I really need like a good fixation, I do like the endotynes.
Yeah, I find that people feel them a little bit,
Yeah.
And
I mean, these are all dissolvable. The sutures are dissolvable. The endotynes are dissolvable, but they take a while, a little while.
They take a little while.
Yeah.
So I think that's the way to do it. And it's great because you do this amazing mobilization of all these soft tissues and place them where you want them. And you fix them in place with sutures, close up a small incision behind the hair that people typically don't see. Albeit there are times where you get some hair loss around that incision, and then you do see it, and you have to do some work to take out the skin that didn't grow the hair back, take out that scar and close it. But for the most part, these heal great. The downside, sometimes the nerve that works the frontalis muscle will be swollen, and it takes some time to recover.
Yeah,
that's not uncommon.
And this gets a little stunned, but it comes back. Give it
always does.
Anywhere from 1 to 3 months, sometimes a little bit longer, but it comes back.
I had one that took like 9 months.
It's
it
so
was
painful.
like a very painful situation. So.
I mean, you can Botox the opposite side.
So it's not the end of the world.
So you don't look like you're like super quizzical on just one side. Like you have a question for me?
I know.
But it's a time. It's a time thing.
Yeah, and it's annoying when it does happen. And I don't know why, I kind of do the operation the same way every time, and I don't know why some people get that. It is something to know about. I have a lot that never get it, obviously,
Right.
but the ones that do, you notice them because you're Botoxing the other side. So by giving Botox to the side that's moving and working normally, you kind of knock it down, and it stimulates receptor growth on the other
Right.
nerve, and it supposedly comes back sooner, which there is data for that, and that's what I've seen. I've never had a permanent temporal branch injury, but they can last a little bit of time, and it's annoying.
It's annoying. And so that is the endoscopic
Right.
brow.
Now let's go to subcutaneous.
Subcutaneous. So the subcutaneous, typically those are incisions that go in the front of the hairline of the brow of the forehead. So kind of right where the hairline meets the smooth skin, you're going to hide your incisions there. And now this is a very superficial dissection. So you go through the skin, you're in that very thin fatty layer directly below the skin. And then it's just a straight dissection down to the brows, and an elevation and an excision of however much skin you need to sort of keep the brows up in a higher position.
Yeah, and I don't love these because the scar is much more visible. I mean,
Right.
you can do them well, and you can do what's called a, it's basically that's a stupid term, but it's basically an incision where you cut through the skin such that the hair will grow through the scar. And by
Theoretically, yes.
you're beveling the incision in that pretrichal region so that you're leaving the roots of the hairs to then grow through the scar that you leave behind. And that sort of works.
Yeah.
I mean, I've seen it where it's been great, and I've seen it where it hasn't worked at all. But this is, it's much easier.
Yeah, this can be done under local. So
Yeah.
the endoscopic one, less likely to be tolerated under local. It's a deep dissection.
It can be done, but it's not fun.
It's not fun for the patient. It's not fun for the surgeon. It's really not fun for anyone. Whereas for the subcutaneous one, this could be a local procedure. Give some lidocaine, numb up the area. It's a superficial dissection. So it could theoretically, if you're doing like a standalone procedure, do it under local anesthesia.
Yeah, and I like it. It's the right operation for a lot of people. You can also do the subcutaneous with the incision behind the hairline, if you so desire. You have to dissect a little further. There may be a little more trauma to the hair. I have found, by the way, you still can get the nerve swelling with this approach and get a frontalis muscle that's not working after.
Yeah, I mean, the
subcutaneous
layers
brow.
here are not thick. And
No.
that nerve that supplies the muscle of the eyebrows runs through all of these layers. It's in a distinct layer, and we know where it is, but these layers are paper thin. So even
Doesn't
if
take
it's
much.
not directly injured, it will be affected by swelling in the surrounding area.
Yeah, like I've only seen one cut nerve by one of by a surgeon who wound up sending the patient to me to what do I do with this? And it kind of recovered, but not really. And that he knew he cut the nerve, which I don't know. I never even see this nerve, so he was obviously in the wrong plane. How we talk about operating in the right plane.
It's important.
Yeah, it is. So, when you know the anatomy, you should not really be seeing the temporal branch of the facial nerve during a facelift or a brow lift or anything. But he did, and he cut it. Which was really sad.
That's
not the right move.
That's not typical.
No, that's a really, really, really rare. And that's the one case I'd heard about it. But, he didn't repair it because he said it was in close proximity. And the concept he had was that it would find its way. And it kind of did a little bit, but I would have repaired it. Should I?
We know how to do that.
Yeah, that's not really a big deal to put a couple stitches in it. Yeah. Anyway, those are sort of the concepts of the subcutaneous brow versus endo brow. And the choice really comes down to what's going to give you the best result. So in younger folks, I think the endoscopic is much better. In folks that are a little late to the dance on their facelift, the subcutaneous is a little better because their skin, even though you're going to move the whole brow as a composite, their skin's still going to be tonic and loose over those deep layers.
Right. The skin itself needs to be excised a little bit.
Yeah. So it's just
it's a tighter result.
Yeah. So I think in the older patient, sort of after 60, maybe 65. In younger patients, it's a no-brainer. Endoscopic all the way, super powerful. It stays.
And you can get the mid-face through it.
Yeah, you get the mid-face, and it is just an awesome operation. And you can do it with a hidden incision.
Yeah, you don't see it. But there are times when sometimes you need to do both, like we kind of referenced earlier. So maybe you've had an endoscopic already, but you still want a little bit more of a lift. Then you can come back and do the subcutaneous underlocal or just touch it up a little bit.
Yeah, and you can use the same incision that you used, and you can get a little more lifting. I've thought about doing biplanars where you do the endoscopic and then actually dissect the subcutaneous plane also. The only thing is with endoscopic brows, and this is a phenomenon that people have to understand, that they look good at a year, but they kind of continue to go up for the second year. And there are reports of them going really high. And so you don't want to overlift somebody because then they look, shocked and surprised, and that's not a good look either. So there's a balance point, and working the result is that's kind of what I like to do. I like to get it where it is and then work the result and get the best looking result possible. And I do that with all my facial aesthetic operations, and quite honestly, I do it with my noses as well. The key is to have somebody that's able to kind of work with you to get the most out of your operation.
Yeah, that's really analyzing you and seeing what's going to work for you. Because the other thing to consider is your hairline and how wide or how long your forehead is. So some of these incisions, if you're excising skin or putting the incision in certain areas, you can actually recede the hairline more than you would want to.
Yeah, if you already have a 5 head, you don't want to do more brow lifting and get up to a 6 head. Right?
No, 5's kind of the max.
Yeah. So if you have a lot of forehead showing, that's hence the term 5 head, you don't want to, pull that skin up even more and get, a even longer forehead.
Yeah. So these are all just factors to take into consideration. And one procedure for one person is not necessarily going to be the right procedure for another. So these are just all tools that we have in our toolkit here, and we individualize them for whichever given patient needs whatever kind of procedure.
How often do you do just the brow lift, or is it mostly a brow lift with a midface?
It's mostly a brow lift with the midface. The exception is the person that comes in and really just wants an upper blepharoplasty, like some skin taken off the upper eye, which I rarely would ever just do skin off the upper eye, because invariably the brows are going to drop afterwards. And the reason for that is because if you're getting to an age where you need a blepharoplasty and skin from your eyelid, the brows have usually started to work over time to lift the brows and that extra skin off of the upper eyelid. And so the eyebrows look like they're sitting in a high position because they're constantly being activated and being pulled up by the forehead muscles to get that extra eyelid skin off of your eyes. And then once you remove that extra eyelid skin and the brows don't have to work so hard, they drop. And all of a sudden people look like they're very mad. They're like, why do I look so mad? I just had a great surgery. So for someone that really just wants that isolated upper blepharoplasty, I say, you know what, we're going to have to do a lateral brow on you as well, just to counteract that potential droppage of the brows.
Yeah, typically when we tell that story, we'll get about 10 phone calls. People going, that's exactly what happened to me. I had a blepharoplasty and my brow dropped and I look mean.
Yes.
Yeah, it's hard to convince plastic surgeons. Well, it's not really the plastic surgeons. It's sort of people that only do eyelid surgery, and they don't want to do brow lifts that don't understand that you should do a brow lift with an upper eyelid
Right, or it's people that had their blepharoplasty done with insurance because insurance will cover it if it's very severe, and they don't, for whatever reason, want to pay out of pocket for what's considered a cosmetic procedure. So that's usually the situation that I see.
Yeah, I tell people it's very unusual that I will do just an upper lid blepharoplasty without a brow.
You have to be 30, just have congenital extra skin that has nothing to do with aging necessarily.
Yeah. If the brow isn't down before your upper lid bleph, it will be if you don't lift it. Yeah, for sure. Yeah. Well, that's pretty cool. I think that kind of covers it on the brow. How long does it take to recover from a brow lift, Dr. Rovelo?
Isolated brow lift on its own, It's not bad. You'll be a little swollen, a little bruised. It'll be swollen, super swollen for 3 days, 7 days, but after about a week, the swelling does really start to come down pretty significantly. People that don't know you won't really look twice at you after about a week, assuming a lot of the bruising's gone away. People that know how you look normally might recognize that you're a little puffy. But I would say, a week, you can probably be out in public without people looking at you twice.
Yeah,
but
I think that's probably true.
Full swelling and full brow position, that's going to be months.
Yeah, it takes a while. If you combine it with the mid-face, do you think that takes a little longer? Or
you're just more
not
swollen.
Yeah.
Your whole face is more swollen as opposed to just sort of like the peri-orbital area.
And surgeons who have this operation done can usually return to work within 2 days. Is that correct?
If they have really good help in the OR. Kidding, not advised. Don't operate right after the surgery.
No. Do as I say, not as I do.
Not as I do.
That's right. But it's a great operation. I mean, I do this on a lot of doctors, actually. Like, I think because they understand it so well.
They understand the anatomy. They're like, yeah, that makes sense.
Oh, I want to get that. Yeah, because it's such a small incision, and you can get so much out of it from a beauty standpoint. It's really powerful.
Yep, I think that's it.
Cool. Well, in that case, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.